Okay, are we ready?
Yes.
Let's go.
Let's go.
For the esophageal. This is actually a very interesting topic for me because this is what keeps me awake always when I'm on duty at the clinics. And when I'm on duty, I was practically every day on duty. So in gastroenterology and in endoscopy, the only emergency cases that you might have is most of the cases will be foreign body retrievals, and a small percentage of cases will be PEG tubes that you placed and that are misplaced. These are the emergency cases in foreign bodies. So let's have a small review on the instrumentation that we use, the retrieval accessories, actually. It depends on what you like most. We have a lot of basket retrieval forceps for objects that are round, that are circular, like small balls, or for example, ping pong balls and tennis balls. The tennis balls are a bit tricky, and I will tell you about that. Snares. We have this for coins that has these two teeth here. We have for clothes these pronged jaw forceps. We have a lot of, and these ones as well are for these 4 or 5 pronged, are for softer material like clothes, socks and stuff like that. And also we have a lot of alligator jaws and rat tooth in order to grasp more harder objects, like, for example, plastic materials or toys or things like that. I will talk a bit later about the gastric balloon removal kit. Let's have a look at the devices for coins and other needles, blades, pins, and stuff like that. It's the rat tooth, because the rat tooth can actually have a very, very hard grasp on hard objects. And also we have other retrieval forceps for bigger bulks, like the alligator jaws or the rat tooth alligator jaws. What I have found, this is something that I do not recommend. It's something that I use though, and I have experience with. This is the balloon that they use, the gastric balloon that they use in humans, because I also attend every Thursday. I would go to a human gastroenterology clinic. So we would place a lot of balloons for obesity in people. And this is actually the device to remove this balloon. And I found that very, very handy for very hard objects that you cannot grasp, because these pins go into this object. The ugly part with that is that if you cannot grasp the object and retrieve it from the esophagus or from the stomach, these pins are so much embedded in the foreign body that you cannot take them out. So you either have to destroy your this kit or cut it somehow, because you cannot. If you cannot remove it, then it's very difficult to disentangle it from the foreign object. But this is very, very handy for big foreign objects that are very difficult to manipulate. They have a very firm grasp. And then there are other things that might accessorize, that might help you in your endoscopic adventure, like the overtube. I tend to use overtubes a lot, and I'm going to show you how, because it protects your endoscope, it protects the esophagus, it protects from sharp objects like scissors or glasses. And like you see here, there is this protective cover as well in for the endoscope, and this protective cover, and this is how the pin gets into the overtube, so that it protects both the patient but your endoscope as well from getting damages. Let's see how we use the overtube. So here we have a bone embedded in the esophagus, and it cannot, I've tried a lot of times with my grasping forceps to move it, but it doesn't move. So what we do is that I've put this overtube, And I'm trying to, this is my grasping forceps, the metallic object that you see is my grasping forceps. So with circular, gentle movements, I am trying to put all the foreign body in the overtube. And this way, I actually succeed two things. The first thing that I succeed is that I always keep my lumen distended. And it's distended with a diameter bigger than the diameter of the endoscope. So as I go out, the lumen is always distended and my foreign body can come all into the lumen. And even if it cannot, this keeps my, it keeps actually my lumen open so that I can retrieve with very, very gentle moves all the foreign bodies up to the esophagus, or even to put them in the stomach, as you saw. Because sometimes it's not easy to retrieve a foreign body, but it's very easy to push it on in the stomach. And if it's plastic object, then you will need, of course, surgery after that, gastrotomy. But if it's a bone, then you don't need, it has been proven that you don't need anything. Rarely dogs have gastritis out of the bones that we proceed into the stomach. And of course, as you saw here, we only estimate the esophagitis only after we have removed the bone. We are going to actually have a look at the foreign bodies that the cats digest, and later on at the foreign bodies that the dogs digest. In terms of cats, cats are smarter. They do not digest a lot of foreign bodies. Dogs are more prone to digest and swallow foreign bodies. And most of the times in the esophagus, we have foreign bodies embedded and lodged in dogs and not in cats. So the reported foreign bodies in cats are strings, needles, fish hooks, bones, and trichobezoars. Actually, trichobezoars is one of the most common foreign body. And if they're left for a long time, they can be really hard, like plastic objects. And where are the common locations? The common locations are where the esophagus normally is narrowed. And this is in the thoracic inlet, in the heart base, and just prior to the cardia, to the lower esophageal sphincter. So we also have an entity in cats that's called chronic esophageal foreign bodies. That's mostly due to the to these trichobezoars, actually. And they cause chronic vomiting, they cause hypersalivation, dysphagia, everything that a foreign body can actually cause. Please always look your cats when they're coming with hypersalivation. We will see a case later on. Always check your cats underneath the tongue. You have to sedate them in order to see them. You see how well embedded this string is underneath the tongue that you cannot see it unless you sedate the animal. And this is a cat that actually swallowed needles. Needles are very easy to come out when they have the thread. So sometimes I say two things to the emergency cases and to my nurses when people call at the clinic. First, if there is a string underneath the mouth, or coming outside of the mouth of the cat or the dog, or in hooks, this string, plastic string, do not cut the string. Do not pull, and do not cut. These are the two rules. Whenever they tell me that it swallowed a needle or it swallowed a hook, the first two instructions that you always give is don't pull and don't cut, because it will be much, much easier for you. I know that it's a kind of reflex of owners and even of vets sometimes, just to pull to see how embedded the hook or the needle is, but this makes it worse. So two instructions: don't pull, don't cut. Okay, it's much, much easier to have the needle with the thread and to take it out rather than having the needle by itself. another needle here. So not all black cats get the needles, some orange cats as well. This is another case. When you have a dog living with your cat, please beware of the colors of permethrin that your dog might be wearing, because we have a lot of cases that cats rub on dogs if you put a permethrin spot on, for example, or that cats might eat, just as this poor black cat. It's different. You can see the towel. It's not the same cat that swallowed the needle. So this poor cat just swallowed the color, the anti-parasitic color of the dog in the family. So the symptoms might start 36 hours, even immediately, but mostly one day, maybe 24 hours after the ingestion. And of course, it always depends on the amount of the ingestion. In this poor cat, it only happened 2 to 3 hours post-ingestion, because as you see, this cat practically swallowed the whole antiparasitic color. So the symptoms were vomiting, hypersalivation, of course, all the toxicosis symptoms, loss of orientation, mydriasis, wide opening of the eyes, twitching, seizures, and of course, labored breathing. So please beware of that as well. Let's go to another very, very common, especially in New Year's Eve. All of my New Year's Eve, you're going to see that the dates on these videos are 1st of January 2016, 1st of January 2017. So practically all of my New Year's Eves, I've been in the endoscopic room retrieving coins, because this is the lucky coins that we put in a pie for New Year's Eve. This coin, this is why you see that this coin is covered, because it's embedded in a pie, but you might have other covers as well. You might have other coins that are not embedded, and I want you to beware of the yellow coins I'm going to show you. So this is a cat, actually, and cats are really, really difficult to swallow coins, but this is a cat, and you can see the esophagus of the cat and the vascularity. We can tell that this is an esophagus of a cat. And I'm going with a grasping forceps. There are other methods to grasp the coins as well. These net graspers that you can just put the coin in the net grasper and close it. This is a very good one as well. So this was the coin, this was the X-ray, and this is a poor dog that has ingested. These are the dangerous coins, and we're talking about zinc toxicosis. Zinc toxicosis is very, very dangerous, because it can cause hemolytic anemia. So the dog might come, or the cat might not come with the symptoms of the foreign body, but they might come with the symptoms of melena and hematemesis and very low blood, very low blood, red blood count, and a very low HCT due to intravascular hemolysis and ictures and tachycardia. So have an X-ray in these animals as well. We always have to do anyways in our diagnostic procedure, because this might be due to a coin. Batteries and coins are really, really poisonous. And these are the foreign bodies that you cannot leave for the next day. You can leave a plastic object in the stomach for the next day if you're not afraid or scared that this will be proceeded in the intestines, but you cannot leave coins or metallic objects in the abdomen. Okay, let's have a case. Let's see our first case. So this is, it's not, you know, while I was fixing these slides, I was reviewing my cases, and is it by luck that all the animals that have swallowed something are males? I don't know. I'm sorry. I have to apologize to the men attending the webinar, but even the cats are male cats. I don't know what to say about that. Anyway, so we have Bella, 10 years old, 10 years old, he's a 10 years old cat, fully vaccinated and dewormed, strictly indoors. There's no other cat in the household. And Bella, what started doing is regurgitation and vomiting episodes. And we will talk in another webinar about how to distinguish. People think that it's very easy to distinguish vomiting from regurgitation, but I'm going to challenge you on that. And I'm going to show you cases that this thin line is not that thin, and that medicine is not black and white. So, but this cat started having both symptoms, both regurgitation and vomiting symptoms. And as you see, this cat is drooling, hypersalivating. The first thing we always do when we have a cat drooling or hypersalivating is check the oral cavity for ulcers, for stomatitis, for maybe a string, as we said. And it is very, very common for cats. You will see that when you have them hospitalized. Cats with GI signs and with vomiting and nausea, what they do is that they extend, they have this neck extension. They always do this thing. This is very, very indicative of a GI disease, something going on in the gastrointestinal lumen. So we had regurgitation with increasing frequency over the last week, vomiting gastric fluids, dysphagia. He wanted to eat, sorry. Bella wanted to eat, but he couldn't. He could apprehend the food, but it was not possible to swallow the food. And the cat actually was vocalizing whenever swallowing the food. Neck extension, as we said, better toleration of the liquid meals than the solid meals, and of course weight loss, not because the cat did not had lost the appetite, but because it couldn't actually swallow the food. So clinical examination, when we saw it, it was 5 out of 9, so it was kind of ideal, the body weight, though it had lost, so it should be a bit overweight before this episode. We had tachycardia, we had dehydration, and probably the tachycardia is due to the dehydration. In the digital palpation, we didn't detect any feces, and you will always do, not on a live cat, on a sedated cat, the digital palpation, please, because I always talk about the digital palpation and people say, how am I going to do a digital palpation? Not on a live cat. You sedate the cat and you see. You always do that in GI cases because you want to detect if there is melena that the owner has not actually detected. You want to see if there's air. Are there any feces? How long has it been since the cat has defecated? Okay. And there was, in the palpation of the cranial abdomen, we had a bit of a pain. Of course, you know that cats are really difficult to exhibit and express pain. So you have to be very, very cautious on how to interpret the pain. There's an amazing scale by Paulo Stiegel, the feline grimace scale, that you can just take a snapshot of your cat and put it in the application, and they will tell you the grading of the scaling of the pain that the cat is in. Paulo has done an amazing work on that, on feline pain and how to detect it, because then it's easier to address it and we always forget about it. Okay. So whenever we have a GI case, what we do, we have to differentiate between these two big categories. The first one is the extra GI, diseases that can cause GI symptoms, that can reflect symptoms to the GI tract, but they are not originated in the GI lumen. And these are intra-abdominal systemic diseases, drugs and toxins, as we previously said, like permethrin, mastocytosis mostly for dogs, Neurological causes, when you have a brain tumor, then you vomit. But this is not a gastrointestinal disease. Okay. Infectious diseases and metabolic endocrine, please, in dogs, do not forget about Addison's disease. I will never stop saying that, because I have a lot of referral cases that are Addisonians, and we, for scoping, referral for endoscopic cases because they vomit and they have diarrhea, and they're not GI cases, they are endocrine patients, endocrinology patients. And in cats, never, ever forget about hyperthyroidism. This cat is 10 years old. He should be checked for hyperthyroidism anyway. So you always palpate also the thyroid gland, and you do a T4 level. That's basic for cats older than 7 years old. Okay. Hyperthyroidism can give both vomiting and regurgitation. Some cats come with regurgitations because hyperthyroidism can cause hypomotility in the esophagus. So if the cat is regurgitating and not vomiting, don't say that it's not hyperthyroidism. Okay. And then we go to the gastrointestinal tract. If we exclude everything extra-intestinal, we go to the gastrointestinal tract and we try to localize the lesion. Just as the neurologist trying to localize the lesion, we try to localize the lesion. Is it an esophageal disease? Is it a stomach disease? A gastric disease? Is it an intestinal, a small intestinal disease? Could it be implicating more organs, like in triaditis, for example, where we have the pancreas, the small intestine, and the liver? Could it be a combination of organs that contribute to the pathology of the disease? In cats, also, when you have a hypersalivating cat, never stop to have as a consideration hepatic encephalopathy, because cats express hepatic encephalopathy totally different than dogs. They do not do these seizures and these neurological, prominent neurological symptoms that dogs exhibit. What they do is that they get aggressive. So we have high aggression, and we have drooling and hypersalivation most of the times in hepatic encephalopathy. Okay, so don't push it out of your differential diagnosis. And these are all the gastrointestinal causes. Of course, we're not going to go through that because we're mostly focused in endoscopy right now. But I want to bring your attention. These are the infectious diseases, enteric coronavirus, FIP, or FELV. Please do all the panels priorly to scope these animals. What are the hematology? Because when you start examining and setting the diagnosis for an animal, you have to start from zero. I have a lot of cases, again, referred that they vomit for 2 weeks and they send them off for endoscopy. We have to take it from step one, which is hematology, biochemistry, then it's imaging, abdominal ultrasound, or an X-ray, and then it's endoscopy. So we have to do things in order. I know that a lot of owners will not pay, but you are the doctors. You are the ones who define the wellness of the animal and what strategy has to be plotted. And you have always to, to tell them what to do. And if they don't, it's their own decision. You always have to suggest, to make the suggestion. Otherwise, they will come and tell you that you didn't make the suggestion up front. So we have an elevated HCT, which is probably due to dehydration. We have a stress leukogram. In cats, you can have, the white blood cells of this cat could be, were around 23,000 white blood cells. Is it an inflammation? Is it a stress leukogram? Cats can have up to threefold up when they're stressed, their white blood cells. So we will recheck that. We'll keep that in mind and we will recheck. Lymphopenia, so we have neutropenia and lymphopenia. It could be a stress leukogram. This rings a bell for a stress leukogram. Okay, the BUN elevated, pre-renal azotemia, dehydration, as we said, the total proteins elevated, again, For the same reason, of course, we have to check the infectious diseases, and this cat was negative for infectious diseases, for FIP, FLB, and FIV. All the liver enzymes normal, the electrolytes due to the vomiting episodes, because regurgitation does not, it can cause hyponatremia, for example, but most of the time, if you have severe hypokalemia, then it's due to vomiting episodes as well. And hypochloremia. So we have a lot of metabolic disturbances here, electrolyte disturbances. This was the X-ray of the cat. Nothing remarkable, actually, to tell you the truth. And let's go to the endoscopy. Can you see this string here? Now we are in the intestine. So we're not in the stomach. We are in the intestine. And we are retrieving back our endoscope in order to see where we are. Okay, so now we got out of the pylorus. This is the pylorus, and the pylorus is so tight, torn in two by this string. Can you see that? This yellow string here. It has shrinked all the pylorus and the intestine on, and this is the incisura angularis. It's like it's cut in half by this string. This is how tense it is. So if you find the string underneath the tongue, don't go on to grasping the string and pushing it or pulling it, because you will only cause damage if this string is in the intestine anyway. So now we're in the esophagus and it goes up. So this string is going from the small intestine up to the stomach, up to the esophagus. Okay, and even if you try to pull it from the esophagus, it will not come out. What we do in these cases is that I have my surgeons do an enterotomy. So they cut the string, they stitch very, very quickly the intestines, and I get the rest of the string from the stomach so as not to have a gastrotomy. I know that for surgeons, it's very easy to have a gastrotomy as well, but I do not want, if we have a scope handy at that point, it is better not to have two sections in the abdomen. An abdomen that's opened, it's never going to be the same. So it's better to do it that way if you have the luxury of the scope. Of course, if you don't, yes, you have to go into the stomach as well and do gastrotomy. Sometimes it's not easy to pull the whole foreign body out of the stomach. And I'm not talking about this small string as well. So these are my collection. I have a big collection of cats that they have. This was actually the cat that was scoped, this yellow string, and you can see how much it was embedded in the tongue. I don't know how many days this poor cat had the string underneath the tongue. And of course, another cat with a red string. Please always check for the strings. Okay. And for Bella, what we did, of course, is to restore the electrolyte imbalances, administer IV fluids, get her to the OP, and of course, second generation, first generation cephalosporins, because the foreign body actually was, we didn't know if it had necrosis in the intestine. So the foreign body was embedded for, this string was there for more than a week, more than 10 days, prophylactic first generation cephalosporins, and then to the OP room. And of course, then nutritional support. You can feed, force feed with a syringe. I place most of the times nasogastric tubes, place them in the correct way, not this way, because they are very, very irritated in their mastocysts. They don't like have the tube on the side. And always beware of the refeeding syndrome. Don't feed huge amounts because the phosphorus might fall, the potassium might fall again, and you can have hemolytic anemia due to the quick refeeding. This is very, very common in humans and in cats. It's not that common in dogs, but please always be aware of the refeeding syndrome. And whoever does not know about this syndrome, go and study about it. Okay, you will become better in your aftercare hospitalization. And of course, we always give B12. A cat that has been anorexic, that has lost weight, needs B12. It's definite that they will have a deficit. We used to do that subcutaneously, but there are a lot of studies now from UC Davis that you can give them orally for a long period of time, and they can do the same. They can be as much efficient. Okay, let's see this case. This case was actually this is a case that was sent by the owner. The video is sent by the owner. And you can see that the dog has very much appetite. It can apprehend the food, and they can have the first stage of chewing very well. But look at the second stage of chewing. Actually, it's when they try to swallow it in the pharyngeal area. Is this pharyngeal dysphagia? Is this pharyngeal regurgitation or something else? So this dog was referred by the vet after this video without being examined, without doing anything. So you see that this poor dog tries to swallow, but it can't. So it wants to expel the food. The food is not expelled, but there is definite discomfort in the pharyngeal area. So it stays there. It's very, very important to understand the stages of the discomfort. Is it esophageal discomfort? Is it pharyngeal discomfort? This is when we're talking about localization of the lesion, this is what we're talking about. So you see how it opened the doors and it cannot swallow the chewed food. Okay, let's go and see what it was. So the minute I tried to scope this animal because he was referred, we did all the blood work and everything, the dog was sedated. And actually this was the first dog that I had with strings like a cat. So it had a string. And fortunate for this dog, the string was only extending to the esophagus, so we didn't even have to scope it. We just took out the string and everything was fine. So it's a pity not to sedate the animal and do an oral examination, a pharyngeal examination before referring it, because you might, win a lot of cases and not refer them to bigger hospitals. Let's go to dogs. I know that the breeds for predisposition are the terrier breeds. These are my best clients, and the small breed animals, the small breed dogs. But I have to tell you that I have a ton of Labradors. I don't know about you. Please write in the chat box. I have a lot of goofy Labradors that eat practically everything. And if we have time in the end, I'm going to tell you a story when I was in Bristol University. And it was actually the second week that I was there. And I'm going to talk to you about this Labrador later on. So most commonly, dogs chew and swallow bones, toys, balls, hooks, and toothpicks, and lots of other stuff, practically everything, clothes as well. And the symptoms depend on where the location of the foreign body is embedded. But most of the times it's retching, gagging, ptylism, repeated swallowing attempts, just as in cats, they do this all the time. Regurgitation, of course, dysphagia, odynophagia. Odynophagia is a Greek word, and it means swallowing with pain, with a painful feeling. So it's painful swallowing, actually. Tachypnea, we have a lot of breathing, especially if we have an aspiration pneumonia and labored breathing. If we have an aspiration pneumonia, let's go and see a bit about the clinical symptoms. What about if we have the foreign body in the pharyngeal or in the pharyngeal part of the esophagus or in the pharyngeal area? I have to highlight that this dog was admitted to the clinic because it was referred for a cardiology case, as a cardiology case or respiratory case, because they thought that it had pulmonary edema. So we put it on oxygen here up until we sedate it and have an X-ray. This is in the X-ray room. You see that the tongue is cyanotic. Whenever you see a cyanotic tongue, always think about an obstruction. Have you seen the sound that this animal is doing? It cannot breathe properly, and it's from the upper airways or the pharyngeal region. So you have always to localize your lesion. This is not lower respiratory disease. This is not heart. The dog was bright and alert, but cyanotic. Something was obstructing the airways. Okay. And let's see, I'm going to show you the endoscopy of this dog later. Let's see about this one here. This has actually a foreign body in the esophageal, in the thoracic inlet. And you see that this dog is gagging all the time. It's doing, even in its sleep, it cannot rest. All the time, it has ptyalism and gagging. You will see another gagging now. You see? It's like regurgitation, maybe gastroesophageal reflex, and it's gagging the poor thing all the time, even in its sleep. Okay. This is a foreign body in the thoracic inlet. It doesn't mean that a foreign body in the thoracic inlet will only have this clinical symptom, but once you see this symptom, just be aware of what it might be behind it, okay? What it might be as an underlying disease. Let's go to this poor poodle. This poodle actually has a foreign body proximal to the lower esophageal sphincter. So you see that it's doing this stretching movements, this stretching of the neck all the time, and it has ptyalism. It never ceases to do lip licking all the time. And it seems that the animal is really, really uncomfortable. Let's go to this one here. This poor one. It is very, very obvious that this dog is in pain, actually. It's very obvious. You can see it shaking. And this is a gastric foreign body. Actually, it was not a gastric foreign body. It was a gastric going into the duodenum foreign body. And this dog had projectile vomitings, had a pyloric obstruction as well. And you can see the movement. What else could we say about these animals? What else could it be? Could be pancreatitis, but something very, very painful in the abdomen. Could it be, for example, spinal cord disease? Yes, could be. So you have to keep your differentials open. Okay. And let's see the situ with the bone. You can see a bone sitting vertically, horizontally, sorry, not vertically, horizontally in the pharyngeal region. So this dog had swallowed the bone, and the bone just stays here in the pharyngeal region. And actually, it was obstructing the airways as well. So the dog could not breathe. This is why the cyanotic breathing and the cyanotic tongue and the labored breathing that it had. Okay, and that was a very easy foreign body to remove. And of course, dogs can, practically consume everything from plastic fans, male dog, from toy materials, male, all ages of male dogs here. And I have a huge, huge collection. And also we have a very huge collection in the children's hospital that I was actually practicing. They have a whole wall of foreign bodies that children might swallow as well. So I have to say that children are more imaginative. They swallow, you know, things that you cannot even imagine. But anyway, toys, a lighter with a pig on it, a toy, bones. That's pretty much my everyday life. Clothes. And sometimes the surgeons ask me, would it be better, for example, to take the clothes out with a gastrotomy? It would be much, much easier and much quicker. And I agree that it might be quicker, but I tend not to open abdomens, even if I have to stay for long in the stomach. I would not, there's only one case that I would not stay long in the stomach, to tangle the pylorus. If you see that in the first 20, 25 minutes, you cannot tangle the pylorus, please do not stay 2 hours and try hard. Because the harder you try, the pylorus will be much, much firmer and closer, okay? So we actually tried to take out every piece of this cloth, and it was fortunate that the clothes had not proceeded to the intestines and that the pylorus was not obstructed. This is the first thing that we actually look in these materials when we have cloth material. Okay, and when you have socks, don't give apomorphine, don't give an emetic agent, just go in and take the, it's good practice, and also it's not good for the, you know, the nausea feeling that the animal is afterwards feeling. And especially if you don't know when the animal has digested the foreign body. So we take out every bits and bits of this cloth, which was, I do not know what kind of a cloth it was, actually. Maybe it was a towel, maybe it was socks, but it has ripped them all apart. Okay, and that's my nurse, Beata, and my other nurse, Livia. There were a lot of people in there. So we went in and out and in and out and harvested all these clothes in order not to have the procedure, the surgical procedure. Okay. And you have to be very, very aware afterwards to deflate the stomach so as not to cause gastric dilation. Okay. And you have to be patient. Sometimes endoscopy is for patient people. Staples, my collection of staples here. This is a whippet. I don't know how many of you know the souvlaki sticks. This is not a toothpick, it's a souvlaki stick. In Greece, people, especially at night, are used into ordering, not burgers, but souvlaki sticks. These are the souvlaki sticks. And if you are lucky that the meat is digested, then it's very easy to take them out. But if you're not lucky and you have to look through it, because sometimes the animals swallow the whole thing with the meat, and it's very difficult to take it out of the stick. And sometimes you only get to see a very small, tiny, this was the tiny, tiny part that you were able to see, and the rest of it is meat. And sometimes the stick is so much embedded in the meat that you cannot take it out. So it's a bit of a hurdle for countries that souvlaki is in circulation. You're going to go with a very firm grasper there, not a rat tooth, an alligator jaw, because you really need strength for these kind of foreign bodies if they are embedded in the meat. Okay. And about this first video, what I wanted to comment on is that sometimes you think it's very easy to take the stick out, but once you lose the grasp in the esophagus, then you just proceed your grasp, and you never get it in the esophagus because you don't have a vertical side, to grasp it. And sometimes you lose it here in the pharyngeal region due to the pharyngeal sphincter. And here we have, I know that somebody raised his hands. We're gonna, please type your question and we're gonna answer all the questions later as well. And we have 5-year-old male again, Westy, that just swallowed a bone. Let's see the scoping. Unfortunately, this dog has not only swallowed the bone. After the bone, they gave him steak. As you can see, there's a lot of meat here. And that was afterwards. They have given him bread. They have given him meat in order to, they thought that this way it would be easier to swallow the bone. The first thing that you do when you have a very embedded bone in the esophagus is to check sideways and to see if the bone is movable or not. And of course, to take all the other materials out of the way so that you can estimate and have a plan afterwards. Set an endoscopic plan on how you're going to retrieve the foreign body. And sometimes, as I said, you can retrieve it. Sometimes you will proceed it, especially if it's bone, into the abdomen, and you will see the damage that has been done. How do we proceed in the abdomen? We either use the tubes that we use for gastric dilation, or the gastric tubes that we use for gastric dilation, or the tip of the scope. The tip of the scope, you have to be very, very careful not to damage your scope. So I'm not suggesting that you're doing it. It needs a lot of experience in order to proceed a foreign body with the tip of your scope without harming your scope. Okay, but it has been described in literature as well. So now what I'm trying to do here is to see if this bone is movable or not, and what kind of damage. You see that I am at the base of the heart. You see the heart pounding here, okay? And you will see here, after the removal, the esophagitis, and also I'm checking the stomach. Mostly what I do is I take the air out of the stomach, because after this trial and all the efforts that we did, the stomach is fully distended. So I take the air out, and then I estimate the esophagitis. This foreign body was only for 2 or 3 hours, and look at the esophagitis, but this is not a candidate for stricturing, okay? And I put my HBE on, which means my hemoglobin enhancer, and you can see how prominent the lesions are. With this Aohua scope, you can see the lesions of esophagitis much easier in order to construct a therapeutic plan after that. And this part has been left, but this is tiny, and I'm trying to shove it off to the into the stomach. I'm trying to push it in the stomach. I don't want to take it out again, because there has been a lot of damage in the esophagus, and you can see that the esophagitis is up to the pharyngeal region. Okay, so once we push it in, we wash the esophagus. Always we rinse it with our either distilled water, and if it's very painful and if the esophagitis is very severe, then I tend to put xylocaine gel diluted with normal saline throughout the esophagus so that it's less painful. Okay. And that was a very, very difficult bone. We actually have tried to retrieve it. This is why you see so much blood. It's from us, because we tried to grasp it with different graspers, but it didn't go out. This is embedded more than 1 week, and these are the worst ones. These are the worst ones. They do not go forward. They do not go back. You either have to tear the esophagus, or you have to be very, very careful. So this bone here was not moving at all. It was embedded. And as you see, it's very, very lodged in the mucosa, in the esophageal mucosa. We actually proceeded the bone with a tube. And I don't have an image of how to proceed it, because I don't do it, I did it blindly. You have to be very careful if you're doing it blindly. You can do it with under visualization with your scope in the tube, but with experience, you get to do it blindly as well. So I did it blindly, and then I checked to see if the bone is in the stomach, and I don't get it out. I take the air out of the stomach, and then I always check for the esophagitis afterwards, after we have removed. And this was a nasty esophagitis in this dog, and this was a candidate for stricturing 2 weeks later as well. This is the incisura. I'm checking the stomach. The dog also has gastritis because this is a regular consumer of foreign bodies and materials. Okay, and you will see, let me check the hour, okay. And you will see the degree of esophagitis as well in this dog. You see how much of a damage. It doesn't even need your hemoglobin enhancer to detect how much of a damage this has done. This dog was very fortunate, and it's just prior to the cardia, this one, to the lower esophageal sphincter. Okay. These are the most common places for a foreign body to be lodged. We wash very well the esophagus. And as we go up, you will see that the esophagitis is only located in the area where the foreign body was lodged. But a huge trauma. Sulcrafate, PPI inhibitors, twice a day, okay. Antibiotics in these cases. Now let's talk about hooks, the story of my life with hooks. They can be lodged anywhere. They can be lodged in the cardia, they can be lodged, here it is in the stomach, in the pyloric region, they can be lodged in the esophagus, anywhere. I do not know if you have a problem with hooks in your country. The most difficult ones are the ones that you have to, that are embedded in the cardia. So you have to work all the time on J maneuver. These are the most difficult ones because first you are afraid you don't have a big range of movements to do. And secondly, you are scared of your scope, what to do with the scope. So the thing to do with the hooks is always to try to precede them forward. So, but always try to see where the tip of the hook might arise, as I did here. So you always try to precede them and take them from the tip, from the pointed tip out. Otherwise, you cannot do it. You cannot, even if you push and pull hard, the hook will be more embedded. This is the only way to take the hook out from this point. And it would be great to have an overtube here, for example, in order to put the hook in the overtube and have the esophagus safer. Okay. Of course, we have other multiple hooks in the pharyngeal region. These are really, really difficult because there is no space here to work. And as I have to point out, you can see that the story of my life is 1st of January 2020, and 2 of January is because it passed midnight. So I had all my New Year's Eve taking out the hook, whoever goes fishing or the dog for a walk, and you know, the dog might eat a hook in New Year's Eve. I do not know. This was a whole new experience for me. So this hook is embedded in the pharyngeal region. You will see it here under the, as we enter the esophagus, under the glottis. Here it is. There's a lot of saliva here. So there you don't have a lot of space in order to assess where the point of the hook is heading. this is a very difficult case, actually. You're so close to get it out, and it's very difficult to get it out because all the structures of the respiratory tract, the glottis, and everything are very close by. You have your ET tube that's pressing the pharyngeal sphincter as well. So even if you're so close in getting it out, it's very difficult to do it on a safe way, I mean. And of course, we always assess the esophagitis and the damage that has been done after the removal. There hasn't been much damage, some blood here just for the trauma from pushing and pulling, from manipulating the hooks. So this wasn't much of a problem. You see how close we are into the, this is the upper esophageal sphincter, the pharyngeal sphincter actually. And this is a very, very stiff sphincter. This sphincter closes and I have to keep my lumen up in order to have visibility, and I don't have visibility. There's no space to work there. The procedure is always the same. You're trying to find the point, the pointed tip, and take it out from the curve of the hook. And this is what I'm desperately trying to do in my New Year's Eve. That was not a coin. I had, you know, a variety. One New Year's Eve is coins, and the other New Year's Eve is hooks. It's a good to have a life of varieties and multiple activities. Okay, now I have revealed the curve of the hook after trying for so long. It took us half an hour to take it out, and it practically takes me less than 15 minutes to take out a hook. You see that we started off at midnight. Actually, it was midnight, and we finished 34 midnight, half past 12. And a lot of saliva, so you have to suction everything again and again and again. And what I'm trying to do now is another technique because it's not being dislodged. So I take my grasping forceps and I'm proceeding it inwards in the esophagus so that maybe if it doesn't come out, it will be in the esophageal lumen. Proceed it and it will be easier for me to take it out. And this is how we took it out actually. So this is why you're seeing me proceeding the forceps. Okay. And this loosens up a bit the tightness of the hook. And at last we took it off. And I'm doing that again. I'm proceeding again inside the lumen. This was it. Such a tiny thing and, you know, do so much damage. Another hook in the esophageal sphincter, and neither the curve nor the pointy thing is shown. That's very scary because you think that it might be in the lungs. Where is the hook? You know, and now we're trying my first movements, your first movements in this case, if you only see the straight part of the hook, will be to recognize in which direction the pointy part of the hook is actually showing. Because if you don't understand that, you will never take it off. So you see now that I'm actually realizing where my curve is and where the pointy part might be. Okay, in order to retrieve it. Otherwise, you will never retrieve it. And this is the very small damage that we did. No bleeding, no nothing. But this is a very, very peculiar place to work because, as I said, there's no workspace. Okay. I'm not trying to push it. I'm trying to see there's a difference. I'm trying to see where the pointy part is being lodged, okay? Where the pointy part will show. And then I'm trying to push it back upwards, as you see. Okay, enough with the hooks. What I want to really point your attention is that there are some foreign bodies that are just staying there in the esophagus without being lodged. And in these cases, it's very easy for you to either proceed them in the stomach or retrieve them like, let's say, a piece of fish or a piece of apple that shouldn't stay there. And then you are heroes, the dog goes home, and then 1 month later, they come again with another foreign body in the esophagus. So you always have to see the underlying cause. There are some, like this very small piece of pear, I think it is, a piece of fruit, just lodged in the esophagus. And you see how much space we have here. This foreign body shouldn't be lodged. Actually, this dog had hypothyroidism. So it had underlying hypomotility. So we always have to be careful. If you see a foreign body that shouldn't be there, or shouldn't be stuck in the esophagus, you should always think about underlying motility disorders, okay? And make the owners aware of the problem and that it needs to be investigated. And of course, we can have delayed gastric emptying due to mechanical obstruction in the pyloric region. I think that I have shown you this one. This is a huge cloth. Actually, it's shoelaces that this animal has chewed, and these shoelaces have made a bundle and they have obstructed the pylorus. You should always, when you're trying to take and test the tension, you should always go back to the pylorus and see if the pylorus is free or not. Otherwise, if there's too much tension, you cannot take the foreign body out. You should tell your surgeon to first cut it from the intestine, as I said, and then release it into the stomach. And what I will do here is that I will try to actually, it stopped. Okay, I will try to actually test the tension. Okay, of course, there might be other causes of obstruction, pyloric obstruction. But what I do is first I go to grasp a part to see how much tension, if it comes easily onto the esophagus. This is a huge bundle. This is a huge bundle, as you see. The whole stomach is full of shoelaces. So I will take some up and then I will leave them into the esophagus, and I will go back to the pylorus, to the pyloric region, and try to unleash some more, and then back to the pylorus, and then try to unleash some more, because you cannot just bring it out like that. Most of the times it's very difficult. So this is up to where it comes, okay, and that's it. It can go no further than that. And then I go back, I leave whatever I have brought in the esophagus, and then I go back and take some more. This is the best I can do in the esophagus right now. So I go back in the stomach and retrieve some more and some more. And when it all comes up to the esophagus, then I'm trying to grasp with a big alligator's jaw, the biggest bundle that I can, in order to try to handle it and take it out. Okay, so now I'm going back to the stomach. I will leave whatever I brought, and I'm taking back to the stomach and bringing some more and bringing some more. So don't just try, because I see some of my residents and they're trying to push and push one edge. It will never come out. It will never come out. You have to go back and bring some more, and back and bring some more. Okay. And as we're watching this, there's a very good question. In case HV, I don't understand, in case a complete obstruction of foreign body in esophagus, do you have any special technique, such as put the balloon to release it or anything else to remove foreign body easily and not to harm or more trauma? Yeah, in case of a complete obstruction of the foreign body, actually, it never happened to me that I could not push a foreign body. Even if I cannot retrieve it, don't be focused on retrieving always the foreign bodies, okay? You can push them, especially if they are bones or stuff like that, you can push them, not the balloon. I never put the balloon dilators because I don't know the actually elasticity of the esophagus at that point. And I do not know if the esophagus will tear up or not. So what I do is I try to put the scope sideways. I will put the over tube in order to see, to check, to open my lumen and see what I can do with my forceps in the over tube. And another thing that you can do is that there are these big forceps that we use mostly in laparoscopy. And sometimes under visualization, though, always, I can cut the foreign body in two. Rarely I do that because I mostly want to push the foreign body, the whole foreign body in the stomach. And it actually works. Believe me, all the bones that we have proceeded into the stomach, none of the animals ever had gastritis or needed a gastrectomy. It's different with the plastic materials, of course. Okay, and to wrap it up, these are some very, very good advice for all of you. It's never good to take out your wedding ring for any reason. This was a gentleman that had come, has taken off his ring, his wedding ring, put it in the next to his bed, as he said, I don't know. And the cat swallowed the wedding ring and he went on like, you know, doctor, please, please take the wedding ring out of the stomach of the cat and I will do anything. And I told him to give his wife a very, very good present. This was a German Shepherd actually that had come, and my residents, it was very, very late at night, and my residents said that, doctor, there is a foreign body in the stomach. We cannot say what it was. And I said, it's a duck. Ask him if, you know, he has babies or if the dog was in the bathroom. And he said, the owner said, oh my God, I left the dog with the baby in the bathtub. Yes. And it was a duck. You can see here the actual face of the duck and the body of the duck. This was an eraser pen. Jack Russell actually has swallowed that. That's a very nice story. And I have a video for that. So this is a Labrador. And this Labrador is called Valentino, okay, because this plays a huge role. So Valentino is in love with the Labrador of the neighbor. So they go out every day, you know, for walks, for long walks. And one day, so this is actually the color and here is the color in the stomach. And I will show you. It was actually the 20th of February. If it was on the 14th of February, Valentine's Day. So Valentino went out for a walk with the dog of the neighbor, the female dog, the female Labrador. And out of his passion for her, he ate all the color. And when I took out the color, it said true love. So this is an amazing love story. Of course, Valentino had swallowed so many other things apart from this color, but this was such a great love story. And if it was not on the 20th of February, but on the 14th of February, it would be epic. But anyway, you know, it was just 1 week after Valentine's Day. And you will see the color. You have seen it in the previous, image as well. So when we took it all out of the stomach, it said true love. Yes, this is true love and passion. Okay. And this is the last case I'm going to show you. This was a case actually, again, on emergency. The dog was not cyanotic. It was very well breathing, pink mucous membranes. And they're calling me, my residents call me, and they say that we have an earring in the esophagus because this Chihuahua actually was licking the ear of its owner, and it swallowed the earring. So I'm coming to the hospital and I see the x-rays and I say, guys, this is not esophageal foreign body. This is a tracheal foreign body. So you always have to, it shows very well here, but the residents thought it was an esophageal foreign body because the animal was breathing so well. And what saved the animal is these 3 holes here and the fact that it was not a closed ring in order to obstruct the trachea. So please always do a DV, might save you time, money, and also, you know, to inform the owner that it's a totally different procedure. And that was the earring that we got out. Thank you so much for your interest in science. Thank you so much for your interest in endoscopic procedures. And if there are any more questions, we can answer them now. Thank you, Jack. Thank you. Thank you. I hope everyone enjoyed it, especially the last tips.
Please feel free to ask any questions.
And even if something is not popping in your minds now and you want to ask later on, I'm always in the... Okay, in a previous webinar, we talked about misoprostol. Yeah. Misoprostol is the only gastric protectant that we use for ulcers, but for prevention of ulcers. Where PPI inhibitors are only therapeutic, you can see that in the BSAVA formulary as well. If you go to misoprostol, you can see it. So the only gastric protectant, if you're giving non-steroidals to an animal that has both prophylactic and therapeutic action, is misoprostol, because the PPI inhibitors are only therapeutic. They do not have prophylactic action, okay, against non-steroidals. I am coming to Romania. We have not set the date yet, but from 15th to 23 of September, this week, I'm coming to Romania. Any other active substance with prophylactic action? There's not even in humans, there's not. Misoprostol is very difficult to be found in Europe as well now. I know that it's very costly, but unfortunately, all orthopedics and even in veterinary medicine, either in veterinary medicine or in human medicine, this is Andrea. I'm really, really sorry. There's no other agent with prophylactic action. All the other agents that we have as gastric protectants are for therapeutic action, like sulfate or PPI inhibitors or H2 antagonist. Everything, all of those are anti-secretory and have a therapeutic prophylactic, a therapeutic action, not a prophylactic one. The only one that's known to have a prophylactic action against non-steroidals, and I'm saying that specifically, is only misoprostol, unfortunately. Special technique to release the complete obstruction in esophagus without harmful. The special technique is to actually put the tube in order to augment your lumen. And another thing is that the tube, the gastric tube, will also help you if you have a huge foreign body in the stomach and you cannot proceed it through the esophageal, the lower esophageal sphincter, then what you can do is you can put the tube in the esophageal sphincter to keep it open, and then bring the scope and your forceps really close to your gastric tube, and slowly with rotational movements try to bring the foreign body from the stomach into the esophagus. This is the only way. I do not use balloons. I do not use ET tubes in order to dilate the lumen. Don't do that, because the pressure that you're putting in the esophagus is not radial, is not isomeric, so it could cause problems and tearing. Thank you, Zaharia, as well. You're an incredible audience as well. The misoprostol 5 to 10 milligrams per kilo, but I have to check that as well. 5 to 10 milligrams. If you check the BSAVA formulary, it's there. 5 to 10 milligrams, but beware that the animal is not pregnant, because it can cause problems with miscarriages. Okay, the same is for humans as well. Thank you, Natalie, as well. Thank you. Thank you. Thank you all. I really appreciate your attendance. Thank you, Andrea. I hope to see you in Cyprus again when I come. So I think that's pretty much it. Whoever has any more questions, Jason can give my email. You can find me in social media. So please don't be afraid to ask. Don't be afraid to share your cases and find a solution together. Always 2 minds or 3 minds are better than one. So we can, together is always better.
Yes, if you want to learn more cases, you can subscribe our YouTube channel. There is monthly we will upload clinical cases. It's supported by Dr. Vasiliki. If you're interested in more cases, just subscribe us. And I want to mention that our webinar is a monthly event. So if you are interested in it, please remember to subscribe our social media like LinkedIn and Facebook, so you will know our next event, and then you will come. And finally, I want to say thank you to Dr. Vasiliki to bring such an amazing and interesting presentation, and say thank you for all the attendees. Thank you for your time. So today our webinar is over. If you still have some questions, please contact us from the social media or from emails. So thank you for your time.
Yeah. Subscribe to our vet. We have a very nice case about of lymphoma in a cat this month. It's a very, very interesting case because I know that you have a lot of difficulties diagnosing and differentiating IBDs from lymphomas. So we have an overview of that this month. And next month, I have a surprise for you. I have a very, very interesting case to show you.
Yeah,
thank you.
So, thank you.
Have a nice evening, everyone.
Yeah, have a nice day. Thank you. Goodbye.